Welcome to Chapter 22, entitled Pharmaceutical Care and Dispensing Medicines. Dispensing prescription medicines is the most frequent activity performed by pharmacists worldwide. It offers pharmacists and their staff the opportunity to discuss the medications with patients and therefore to contribute to the care of individuals in order to optimize medicines use and improve health outcomes, abbreviated as PCNE. By providing pharmaceutical care around the dispensing of medication, pharmacists may help the patients make the most of their medicines and of treating, controlling their disease or diseases. A number of protocolized services can be recognized in practice in different countries. For new medicines that are dispensed for the first time, there are several examples of pharmacy services that try to preempt non-adherence, amongst others. For repeat prescriptions, maintaining the therapeutic relationship, checking for problems in those most at risk and avoiding normalizing poor and declining health are activities that the pharmacist and the pharmacy staff can take to help patients. Whatever activity pharmacists and their staff undertake, they must be based on the good pharmacy practice guidelines, and be properly documented like all healthcare activities. We will now discuss dispensing and medication use today. For many centuries now, doctors have prescribed medicines, and pharmacists dispensed them. But in order to create the most benefit for the patient, the dispensed medicines should not only be of good quality, but the dispensing process should also assist the patient, or medicine user, to have the most benefit of them. As Hepler and many others stated, the outcomes of the medication therapy should be the concern and responsibility of the pharmacist. This means that the task of the pharmacist does not start nor end with the mere handing over of the medicine. According to the WHO, when faced with a prescription, the pharmacist verifies the legality, safety and appropriateness of the prescription order, checks the patient medication record. When such records are kept in the pharmacy, ensures that the quantities of medication are dispensed accurately, and decides whether the medication should be handed to the patient, with appropriate counseling. But in many countries, dispensing prescription medications has become a high-volume, routine activity. As a result, the focus is on the dispensing only, and undetected errors and problems may occur and patient harm can be caused. On the other hand, dispensing is the moment where the patient, or his caregiver, usually is in the pharmacy and easily accessible for counseling and care provision. A focus on efficient dispensing only may cause this moment not to be used properly. Next we will discuss dispensing and providing care. Dispensing is a routine activity for a pharmacy, but providing pharmaceutical care in many countries may not be. Inserting the elements of pharmaceutical care into routine dispensing requires careful thinking, targeted implementation strategies. See chapters 18, 19, 20, and 21. Rerouting of routines, motivated pharmacists and staff, and optimal cooperation with other care providers such as doctors and nurses. The routine dispensing process will undoubtedly be affected by providing pharmaceutical care. Usually prescriptions are generated by a physician. However, increasingly pharmacists also may create a prescription, either through pharmacists prescribing, or through synchronization procedures for repeat prescriptions. A pharmacist advice regarding OTC medication in some countries may also be called prescribing. In the first stage of pharmaceutical care, see the pharmaceutical care cycle in Chapter 1. During dispensing in any pharmacy, the goals of the therapy must be clarified. Then the optimal pharmacotherapy for this individual patient must be assessed, taking into account possible interactions and contraindications. At the dispensing moment itself, appropriate patient-oriented counseling must be given, and after the start of therapy, possible drug-related problems must be evaluated and dealt with. And all activities must be properly documented, before, during, and after the dispensing process. Separate chapters in this book are dedicated to most of these activities. In general, the licensed pharmacist will have the knowledge and skills required for the provision of pharmaceutical care. However, in order to be efficient, usually the pharmaceutical care provision around dispensing is a shared responsibility between pharmacists and their staff. Where in this chapter, pharmacist, is written, one could also read, pharmacy staff member, provided that delegation of activities has been properly protocolized or described, and the staff member has been educated for the task. See Chapter 40. Next we will discuss integration of pharmaceutical care processes. Let's first look at checking of the prescription. As indicated before, in daily pharmacy practice, the care-related processes must become integrated in the dispensing, handing over, process. At presentation of the prescription in a pharmacy, a validation or review must take place of both prescription and patient. The new prescription must be integrated into the pharmacotherapy plan or pharmaceutical care plan. This involves not only a dosage and drug-drug interaction control, but also a re-assessment of therapeutic goals. Usually additional information is required, for which the patient or his carer is a primary source. If needed, other caregivers can be contacted. To prevent medication errors and drug-related problems, it is essential that medication reconciliation and prescription review are completed before any dispensing starts. Actions such as contacting the prescriber to avoid medication errors or drug-related problems must have been taken before dispensing. A change in dose, in regimen, or in formulation may be simple to effect, and in some jurisdictions changing prescriptions in this way is within the pharmacist's scope of practice. Changing the medicine, an addition or discontinuation or switch to another medicine, is more complicated both clinically and legally, and usually will require the agreement of the prescriber. Generic switching seems somewhat easier to accomplish. Such extensive review activities as described above are usually not necessary for repeat prescriptions, unless the patient has developed a new ailment or disease, or the dose of the medicine has been changed. On the other hand, the prescription review may also indicate the need of a full medication review and reconciliation, which then has to be carried through. See Chapter 7. In terms of patient care, the dispensing of a medication for the first time is often an important clinical event and should trigger an assessment to determine how familiar and prepared the patient is to begin the new medication and to integrate it into the existing treatment and lifestyle. Similarly, it can be important to monitor the second time dispensing. However, dispensing to patients who have been discharged from hospital, or who have just been admitted to a nursing home should also be treated as new, because moving from one setting to another is a known risk factor for adverse health outcomes, many of which are medication-related. Checking the medicine's compatibility with other medicines and diseases of the patient is in some countries done with the help of a computer and patient file and is called medication surveillance. Table 22.1 shows a list of patient and medication-related information that ideally is required for assessing the appropriateness of a new prescription and counseling urgency, apart from the medication history. Prescription review. Prescription validation or medication surveillance is often described as a purely technical activity that would not necessarily involve the patient or consultation of medication history records. But as with all routine tasks in healthcare, the detection of ambiguities, inaccuracies, errors, and potential errors at this stage will protect patients and trigger the provision of pharmaceutical care for those patients in need of it. It is therefore essential that medication reconciliation and prescription review are completed before dispensing starts, and accesses to the patient or caregiver is preferable. The need for necessary counseling activities can already be signaled during the review, and then initiated when the medicine is handed over the patient. Pause the video and carefully scrutinize Table 22.1 summarizing patient and medication-related information for assessing a new prescription before advancing to the next slide. Next we will discuss preparing the medicine or medicines. Once the prescription is found appropriate for the patient, the medicine can be prepared. In some countries, this involves also preparing a label with the name of the patient and preparing essential instructions about the medicine use. The required information on a pharmacy-prepared medicine label in, for instance, the Netherlands is as follows. 1. Name, address, and phone number of dispensing pharmacy. 2. Date of dispensing. 3. Prescriber name or prescriber code. 4. Name and address of the patient. 5. Date of birth of the patient. 6. Daily use of the medicine. 7. Warnings concerning the way the medicine must be used, e.g., swallow whole. 8. Name and strength of the medicine. 9. Number of dispensed units. As for the information provision, this has to be verbal as well as written. In spite of regulations in most developed countries, there are doubts about the usefulness and quality of the information leaflets that the pharmaceutical industry provides. In some countries, the patient information leaflet, abbreviated as PIL, can be individualized, and tailoring information leaflets to patient characteristics and requirements would enhance effectiveness. It gives a nice and useful touch to the provided care. In other countries, there are legal obligations to hand over an information leaflet, be it a customized one or a leaflet prepared by the producer. The written information needs to be prepared and added to the medicine. Once the medicine with its information is ready, it can be dispensed. In many cases, the prescription review, preparation of medicines, and the dispensing are done by different persons in the pharmacy. The continuity of the process is then an additional concern. And now we will look at handing over the medicines. Handing over medicines to a patient, or his caregiver, seems a simple task. But this is also the moment that counseling must be given, instructions provided, and an assessment must be made as to the health literacy and mental capacities of the patient. It also is the moment where the adherence to medicines can be influenced the best. See Chapter 5. For continuity and documentation purposes, certain aspects that must be stressed at the dispensing moment should have been marked on the prescription, or an added leaflet, during the prescription review and the preparation of the medicine. In several countries, the process of handing over medicines has been protocolized, as to make sure that all care activities are done, where appropriate. This element of quality control is further discussed in chapters 9 and 10. Most people do not appreciate the curious eyes and ears of their neighbors when receiving medicines, so from a pharmaceutical care perspective, the counter should be constructed in a way that privacy is possible. Specific instructions for the use of devices such as inhalers, or counseling on sensitive topics should be given in a separate room. We will now discuss dispensing, review, follow-up, and documentation. Perhaps dispensing review is a heavy word, but the dispensing of every prescription should be reviewed. Have all checks been done? Have all advices been given? Did the right patient receive the correct medicine and counseling? Have the chances of medication errors been reduced sufficiently and the optimal chances for positive outcomes of the pharmacotherapy been created? And for future reference, have possible allergies been documented? The check of such aspects usually is the responsibility of the managing pharmacist. Depending on the computer system, the care activities can be documented on the prescription or in the system. This type of documentation can be compared to what medical doctors are supposed to do. They also must document all their activities and thoughts on a given person, for instance in SOAP notes. For care-providing pharmacists, this is not different. Detected drug-related problems can be documented, often also using SOAP notes, and with the help of the appropriate classifications, see Chapter 8. A telephone follow-up, also called call-back service, from the pharmacist helps solving patients' problems with a new medicine after the dispensing and can significantly reduce non-adherence and costs. Next we will discuss protocols for dispensing. As shown above, dispensing in the context of pharmaceutical care is not a simple task. It requires general pharmacotherapy knowledge and different skills. To assist practitioners in practice to dispense medicines in the most responsible and reproducible way, protocols can be drafted. Such protocols must be adapted to the practice setting, local legal requirements and patient population. Especially the first-time dispensing of a new medicine needs a good structure. In many countries, protocols have been developed by professional organizations in an effort to guide pharmacists to act in a standardized and evidence-based manner. One of the most international recognized guidelines is the FIPWHO Guidelines for GPP, that is Good Pharmacy Practice, which have evolved over the years incorporating the advances of pharmacy practice. These guidelines can be used as cornerstone for the drafting of practice protocols. In many countries, these good pharmacy practice guidelines have been used as a basis for local protocols and guidelines. Adherence to protocols can be self-assessed so that the pharmacy team can improve them, but they should also be regularly audited by an external agency. The following flowchart indicates the difference between dispensing repeat prescriptions and dispensing a new prescription, and how it may impact the activities in the community, or polyclinic, pharmacy. Figure 22.1. Pause the video and carefully scrutinize Figure 22.1 illustrating pathways for dispensing before advancing to the next slide. Pause the video and carefully scrutinize Figure 22.1 illustrating pathways for dispensing before advancing to the next slide. Next we will focus on the new medicine services. Several countries have established a new medicines service, although each with some specifications either regarding the setting and moment of care provision, e.g., post-discharge in the UK, regarding the patient group, e.g., cardiovascular patients in the UK and Norway, asthma patients in the UK and France, or the medication group, e.g., inhaled steroids in Belgium, vitamin K antagonist in France. Despite minor variations, the service has general characteristics which focus on an initial service dealing with the provision of information about the indication of the drug, its necessity and any specific and relevant indications, e.g., how to take, or what to avoid. Usually a follow-up visit is also part of the service. Maybe more than one and maybe long distance or face-to-face, where additional information is transmitted, which focuses on more specific topics that are likely to arise only after the medication has been initiated. In Portugal, although this service is not yet implemented as a nationwide service, some pharmacies have developed their own protocols to guide pharmaceutical intervention, which again follow the same principles. Community pharmacists in the Netherlands are expected to provide additional care and service to all patients who present with a prescription for a new medication. The service in the UK has primarily been developed to improve adherence and is remunerated separately. It is called an advanced service for which a separate accreditation is needed. In most other countries, this type of service is regarded as part of the normal pharmacy care services. A study by Elliott and colleagues, published in 2017, suggested that the NMS increased patient medicine adherence compared with normal practice, which translated into increased health gain at reduced overall cost. And finally, let's discuss repeat prescribing. With repeat prescribing and regular inquiry about the patient's health status, their experience of their treatment and their satisfaction with their treatment may lead to a conversation in which one or more drug-related problems become apparent. Such conversations can be protocolized. The dispensing of repeat medication is an appropriate moment for such conversations. Additionally, a regular medication review for complex patients, complex diseases, complex medicines, may unveil problems too. Since it is not possible to carry out an in-depth investigation of every patient receiving repeat medications for long periods, there must be a strategy to select the patient most likely to need additional care. In several countries, specific patient groups with specific chronic diseases have been targeted for additional pharmaceutical care. Cardiovascular diseases, asthma and chronic obstructive pulmonary disease, and diabetes mellitus are common diseases for which pharmacists give additional protocolized care, sometimes also bridging the gap between different care providers and care institutions, seamless care. In the Netherlands, all patients older than 70 and receiving more than 5 medicines must receive a regular and remunerated Type 3 medication review. Some other countries have similar requirements for patients that receive a certain minimum of chronic medications. In some countries, the focus of counseling as part of the care for patients with chronic medication has moved to the second-time dispensing of a medicine. Some patients are confused when they hear for the first time that they must take a medicine chronically and do not listen properly to the first-time counseling. All in all, dispensing repeat prescriptions require a different approach in the pharmacy. They can be a trigger for extended care, extended counseling, or be part of a disease-oriented pharmaceutical care plan. Thank you.